Good evening, my dear students, and welcome to this webinar or online class on varicose veins. Varicose veins is an important topic even for clinicals as well as for theory examination. You must understand the basic of how the varicose veins will manifest and what are the problems are which are due to the varicose veins and how you have to manage these patients. Now, varicose veins, if you look at that, the normal blood from the lower limb usually starts from below and travels upwards towards the right heart. Now, these venous systems are one on the medial side, which is the great saphenous or long saphenous system. Another one is the short saphenous system, which is on the lateral aspect. These two are the superficial venous system. The deep ones are the popliteal vein, which becomes the femoral vein and joins the external iliac vein. The normal blood flow is from below upwards, and there are many valves situated in this long saphenous and short saphenous system which prevent the blood flow from above downwards. So that means the flow of blood is unidirectional from below upwards, and these valves will allow only in the direction from below upwards only. And this is the normal venous anatomy. But in varicose veins, what happens? The valves are not competent, so the blood keeps coming in the veins from above downwards also. This is due to venous reflux. Now, since the venous reflux is there, and there is a long column of blood which is seen in the veins start bulging and it becomes tortuous. So this abnormal dilatation and tortuosity of the superficial venous system is known as varicose veins, which is in relation to the lower limb. Varicose veins can also be seen in esophageal varices, patients with cirrhosis, portal hypertension, and then they can have portosystemic anastomosis in the anorectal junction and in the spermatic cord, which is known as varicocele. So there are many places where the veins can dilate and become symptomatic due to its presence and by bleeding. So the definition of varicose veins is the dilated, tortuous, worm-like veins which are seen in the lower limb, and this involves the superficial venous system. So basically I mentioned it is enlarged, tortuous, and they are bulging. Visible veins which are tortuous and bulging is due to the varicose veins. Sometimes veins can be visible, but they are not varicose veins. But when they are enlarged and tortuous and like worm-like, then it is known as varicose veins. And because of this, there will be nagging pain in the leg. So this is the most symptom which majority of the patients will come about. Others may be because of the cosmetic region, but many of them will come because of the pain in the lower limb, which becomes more on walking and on standing for long duration. Now, what are the causes of these varicose veins? Simple thing to remember is the mnemonic HLA, HIV, DC. You would have heard about HLA antigen, HIV infection, and direct current DC. So a simple thing to remember the etiology is HLA, HIV, DC. In the HLA, H is hormonal. Because of hyperestrogenism, the veins can dilate, especially happens in pregnancy. In pregnancy, it is also due to the pressure effect. Then lifestyle. Lifestyle, people who are long-standing, like teacher's job, somebody postman, who have long-standing history and they have their work itself involves standing for longer duration, they will develop. And the A is acquired varicose veins. So it can be congenital or it can be acquired. So HLA is hormonal, lifestyle, and acquired varicose veins. Now, the second part of the mnemonic, HIV, high estrogen status. This happens in pregnancy, and these patients are more prone to develop the varicose veins. It can be hormone producing ovarian tumor. Because of the hormone as well as the size of the tumor, it can give compression over the abdominal vein, and that can manifest with varicose vein. Then inherited. Some families, there is family history of varicose veins. So the HIV is high estrogen state, inherited, and majority of them is due to venous valvular incompetence. Now, this is the problem in acquired as well as in inherited variety. The valves, which normally regulate the flow from below upward, become incompetent, and there will be reflux of blood from above downwards, causing dilatation of the veins. Now, other important thing is the deep venous thrombosis, especially postpartum. These women develop deep venous thrombosis. Since the deep vein is thrombosed and the lumen is obliterated, the alternative path for the blood to flow from the lower limb towards the heart is the superficial system. So when there is deep venous thrombosis, the superficial system dilates and becomes tortuous, and the veins become prominent and can become symptomatic. Now, there are some congenital syndromes like Klippel-Trenaunay syndrome. In these situations, there can be congenital varicose veins along with limb hypertrophy. So all these are all congenital. So simple thing to remember, the etiology of varicose veins is HLA, HIV, and DC. So I hope you remember at least HLA, HIV, DC. HLA part is hormonal, lifestyle, acquired. HIV part is high estrogen state, inherited, or venous valvular incompetence. Now, DC is deep venous thrombosis and congenital syndrome like Klippel-Trenaunay syndrome. Now, see, look at this. Which system is involved? This is the short saphenous system. It is on the posterior aspect of the leg and towards the lateral side. So this is the short saphenous system, which arises on the lateral side of the foot and then gradually ascends. This short saphenous system joins the popliteal vein behind the knee joint. So when there is problem here in the popliteal vein and the short saphenous vein system junction, valvular incompetent, blood starts regurgitating. And this is the short saphenous system. Now look at this. Usually in normal vein, blood, like I mentioned, blood flows from below upwards. And when the blood tries to come back, the valves prevent the flow of blood towards the lower veins. But in incompetent valves, the blood regurgitates into the lower veins, causing the distension of these veins. Now look at this. These are all nicely distended tortuous veins. These are all, in smaller in size, but they are like spidery appearance. These are known as telangiectasia, whereas these are known as varicose veins. So depending on the size of the veins, it can be like ankle flare, malleolar flare, or it can be telangiectasia, or it can be varicose veins, which can be really visible and it is normally compressible. So this is the basis, the retrograde flow, valvular incompetence, which manifests in distended veins. Now, basically, to understand the pathophysiology, now varicose veins are due to the patient factors like congenital, familial, environmental factors like long-standing job, teachers, postmen, and genetic predisposition. Along with that, the hemodynamic factors of long-standing and the column of blood stays in the long saphenous system. This increased venous hypertension can manifest with valvular incompetence. So all these cause the varicose veins. Now, since there is stasis of blood in the saphenous system or the superficial venous system of the leg, there will be local hypoxia. And this local hypoxia will cause cellular damage and apoptosis and dysregulation of cellular maturity, which will cause various manifestation in the leg. And there will be alteration of extracellular matrix formation. So because you should remember, it is due to the genetic predisposition, environmental factors, patient's factors like occupation, and because of that standing, there is increase in venous hypertension, which all of these contribute towards formation of the varicose veins. And because the blood is staying in the long saphenous system, there is local tissue hypoxia, cellular hyperplasia, and apoptosis, dysregulation of the cellular maturity, and the alteration in extracellular matrix formation, which can give rise to various manifestations of varicose vein, which we will be dealing later. Now, basic thing you must remember is, number one, to know whether it is superficial system, whether it is long saphenous system or it is the short saphenous system. There is a classification known as CEAP or CEAP. You must remember this CEAP classification. Now, C stands for clinical classification, E stands for etiological classification, and A stands for anatomic classification, and P stands for pathophysiologic classification. So you must remember CEAP or CEAP or CEAP classification of chronic venous disease. Now, when it manifests longer than 6 months to 1 year, you call it as chronic venous disease. And the classification is known as CEAP or CEAP classification. Now, C part of it, it is clinical. C0 is no visible or palpable signs of venous disease. C1 is telangiectasia or reticular veins. That is what I showed in the previous diagram. C2 is other one I showed, varicose vein. So C0, no visible palpable veins. C1 is telangiectasia, reticular vein. This is the early manifestation. C2, when the veins become larger, it is varicose veins. And because of this complication, C3, if the limb is edematous because of the varicose vein, then it is known as C3. C4 is divided into A and B. C4A is pigmentation or eczema. 4B is lipodermatosclerosis, which is a specific entity and it causes atrophy of the skin. Then C5 is healed venous ulcer. C6 is still non-healing ulcer. So it's very clear. CEAP classification, C stands for clinical classification. C0 is no visible palpable signs of venous disease. C1 is telangiectasia, reticular vein. C2 is varicose vein. C3 is limb edema. C4 is into A and B. A is pigmentation and eczema. B is further manifestation, lipodermatosclerosis or atrophy of the skin. 5 is healed venous ulcer. 6 is open venous ulcer. Now, along with this, if the patient has got symptoms, then you call them as symptomatic and this portion, whatever the level is, or it is asymptomatic with whatever level. Now, etiology, these three are easy to remember. EC is congenital, EP is primary, ES is secondary. That means it is post-DVT. So EC etiology is congenital, EP is primary, ES is secondary. And if you are not sure what is the thing, then you put it as EN, no etiology identified. Then A, anatomic classification. It involves superficial system, AS. If it involves the perforator veins, it is AP. If it involves the deep vein, AD. And this diagnosis is usually done by Doppler. And when you are not sure, AN, no venous location identified. So C, E, A. Now P. P is one is due to reflux. This happens PR, that is due to reflux. This happens when the blood from above comes down because of valvular incompetence. And this is known as PR. Now, PO, obstruction. If there is obstruction of the venous system, the superficial system dilates. And this is known as PO or due to obstruction. When there is combination of both, then you call it as PRO or reflux and obstruction. When you cannot make out anything, then you put it as PN. No obvious pathophysiology could be identified specifically. So this you must remember. This will help you in remembering and classifying the disease as such and how to decide on the management. So CEAP classification, clinical, etiologic, anatomic, and pathophysiologic classification. C only has little more number, whereas E is congenital, EC, EP, ES, EN. Same thing with A, AS, AP, AD, AN. Reflux, PR, PO, obstruction, PRO when both reflux and obstruction are there. PN is when no obvious pathology could be made out. So this is the basic classification, and it is easy to remember, and you have to diagnose the venous disease and tell which system is involved, what is the stage of the disease, and then to decide about the management. I hope it's clear. Please remember this. This will help you long way. Even when you are going to do masters in surgery, this will help you further. Now, what are the symptoms these patients can have? One is obvious cosmetic reason. The patient may come and say there are dilated veins on my legs and which are looking obvious. But then the symptoms can manifest because of the venous stasis. There will be tightness in the calf muscle and ankle. Because of the edema and the blood which is staying there, there can be eczema which cause itching of the lower limbs. And then there can be because of there is leak from the vein valves. So this blood, when it leaks out into the subcutaneous tissue, there will be deposition of hemosiderin pigment, and this causes extensive skin reaction which becomes eczematous and indurated. And this is around the thing which will cause numbness because of the neural damage, superficial nerves which can damage, and this will cause numbness. And like I said, most of the time the stasis is longer, the patient will have pain, but they will have more pain while walking and standing for long hours. So these are the symptoms which can manifest in patients with varicose veins. Now, other things are brown leathery skin. This is due to hemosiderin deposition, which causes pigmentation, eczema, erythema, then itching, ulceration, and this skin becomes indurated, hard, and there is tissue fibrosis, which will cause typical manifestation, which is known as atrophic blanche. And this is the typical manifestation of long-standing chronic venous insufficiency or varicose veins. Then what is known as, even lying down, they can have some pain. This is known as restless leg syndrome. And usually this is seen in arterial deficiency. But even in varicose veins, they can manifest with this restless leg syndrome. Muscle spasm, and last complication is the ulceration, which becomes chronic. That means the ulcer has been there for more than 6 months duration, and this ulcer is known as chronic venous ulcer. Now look at the skin. See, there is eczema, erythematous, brown is pigmentation, then itching, there is ulceration. So this is the manifestation of varicose vein. This is known as erythematous, eczematous, indurated skin, and this pigmentation is due to hemosiderin, and which causes fibrosis, constriction. See this around the ankle, there is narrowing compared to this foot, this leg, and there is distended calf muscle. See the size of this calf muscle and this one. So there is inverted champagne bottle appearance. That is due to distended calf muscles, narrow ankle because of fibrosis and ulceration, and all this manifestation of the varicose veins. So this is typical feature, which is distended calf looking bigger than the normal side, narrowing at the ankle compared to the other side, eczematous, pigmentation, erythematous, heel, scaly skin, loss of skin appendages like hair, sweat glands and all will happen. And last, the ulceration, which will become chronic if it is longer than 6 months. Now, some important terminologies you must remember in varicose veins. One is known as lipodermatosclerosis. Now, this is typically seen in varicose veins of long standing or long duration. There is discoloration of the skin around the site of varicose vein. That is due to Hello?
Yes, sir.
Screen, is it seen?
Can you please share your screen, sir?
Now?
Yes, sir, we can see it. Please continue.
I think there are some internet problem. Yeah,
Okay.
fine.
Okay.
Now, lipodermatosclerosis is a specific terminology, and it is the manifestation of long-standing varicose veins. There is discoloration of skin because of hemosiderin pigmentation, brownish discoloration, and it becomes rough and leathery, scaly, and it becomes indurated. This is all due to reaction of the hemosiderin in the subcutaneous tissue. Then the skin becomes inflamed below. So there is the fatty tissue underneath the skin becomes inflamed. So that's why it's called lipo. Then skin becomes fibrous, rough and leathery, dermato. Because it is rough and leathery, you call it as sclerosis. So fatty skin changes, that is why it is known as lipodermatosclerosis, and this is due to the blood which is coming out of the vein because of the veins become vein valve becomes leaky, and because of the hemosiderin, which can cause reaction. Now, this is the typical picture of lipodermatosclerosis. See that skin is scaly, pigmented, dark brown, and there is sclerosis of the tissue. And because redness is because there is inflammation of the fatty tissue. And this narrowing around the ankle, calf muscles which are distended. This is typical feature of inverted champagne bottle appearance. And this is due to long-standing venous insufficiency, which causes this lipodermatosclerosis. See other one with prominent erythematous changes. This is because of the inflammation of subcutaneous tissue, scaly, there is prone for infection, and it will be itchy. See the calf muscle so dilated, and the ankle which is narrow because of fibrosis. So this is the manifestation of lipodermatosclerosis. Now these are all the stages of this. See, this is an ulcer. Normally the manifestation of an ulcer is at the medial side of the leg, just above the medial malleolus. And this area is known as gaiter area. In the last class, we were discussing about that examination of an ulcer, where we went in detail with venous ulceration. And this is classical manifestation of a varicose ulcer or venous ulcer. And it is usually seen at the ankle, just above the ankle joint in the leg. And this is known as gaiter area. The ulcer can heal and become shiny, which is leathery, skin is thin, the skin appendages all disappear, or ulcer can recur. So these are all the manifestation of a long-standing chronic venous insufficiency. Now, examination of these patients is very important to look at what is the cause. Now, basically, examination, like I said, it can manifest from the long saphenous system, or it can involve the short saphenous system. Now, the long saphenous system, like I mentioned, it involves the long saphenous or great saphenous vein. It starts from the medial aspect of the foot, and it ascends along the leg about 2.5 centimeters medial to the medial malleolus, ascends and goes posterior and comes medial to the thigh and enters the deep fascia or the cribriform fascia, and this opening is known as saphenous opening, and the long saphenous vein enters into that and deeper to the deep fascia joins the femoral vein, and this is known as saphenofemoral junction. Now, important thing to make out is there are two veins here, two valves in here which prevent reflux from the deep system to the superficial. One is here proximally, other one at the junction of the saphenofemoral. Now, this is one of the major causes of gross reflux because the long-standing direct pressure in the venous column. So we should be able to make out what is the thing. Now, when you are looking for the saphenofemoral junction, it is usually below the inguinal ligament. Now, when you follow the adductor longus tendon, it will reach the first bony prominent, that is the pubic tubercle. Now, this from there, it is about 2.5 centimeters lateral and below. So that is the area for saphenofemoral junction. And this you must remember, it is below the inguinal ligament and it opens into the femoral vein below the deep fascia at the fossa ovalis or saphenous opening, and it is 2.5 centimeters to 4 centimeters lateral and below the pubic tubercle. And when you occlude here, when you make the patient lie down, empty the vein and apply pressure over this region and ask him to stand. If the veins do not become prominent, that means it was due to saphenofemoral junction or the valve abnormality. Saphenofemoral valve is incompetent. But when they stand and you release the pressure, suddenly you see the flow of blood from into the superficial system, which indicates that saphenofemoral valve is the culprit causing the reflux. So this is very clear. You must be able to locate this. And this can also be shown by tying a tourniquet here. And this is known as Trendelenburg test. So Trendelenburg test is to make out what is the level of incompetence and is it the saphenofemoral junction. So this is basically anatomy. You must remember it is 2.5 centimeters below and lateral to the pubic tubercle. And pubic tubercle you palpate from below upward, go along the tendon of adductor longus, and the first bony prominence you feel is the pubic tubercle. And same thing with the anterior superior iliac spine. You go from medial to lateral along the inguinal ligament, and the first bony prominence you feel is the anterior superior iliac spine. So you must remember how to palpate anterior superior iliac spine, pubic tubercle. These are all important even for when you examine an inguinal hernia case. Now, like I said, the great saphenous system opens into the femoral vein at the fossa ovalis or saphenous opening. Along with that, there are some tributaries which can open in. One is the superficial external pudendal, then superficial circumflex iliac and superficial epigastric. So these three are the common tributaries which have to be ligated flush, and then saphenofemoral vein has to be ligated flush at the junction. So these named tributaries are very important. One is the superficial external pudendal, superficial epigastric, hello,
Yes, sir.
hello,
Yes, sir. Yes, sir.
audible?
Yes, sir. You're audible, sir. You can continue.
Okay. Now, like I mentioned, the long saphenous system connects into the deep venous system also by known perforators. And the perforators which are known are one at the mid-thigh level, and that is known as Hunter's perforator. And there are some perforators which are one hand breadth above the knee joint and one hand breadth below the knee joint. And these are known as Boyd's perforator. See, at the mid-thigh is the Hunter's perforator. At the knee joint, it is the Boyd's perforator. And there are three normal perforators which are situated here at the ankle from the medial malleolus. It is 5, 10, 15 centimeter. So this is the measurement of the thing. And normally these perforators are seen at 5, 10, 15, and these are known as cockets or Boyd's perforator. So near the knee, it is the Boyd's perforator. Near the ankle, it is the Cockett's perforator. Mid-thigh is the Hunter's perforator. Now, the lateral saphenous or the short saphenous system starts on the lateral aspect, ascends posterior to the lateral malleolus, and there is a perforator joining the short saphenous system to the tibial vein, which becomes the popliteal vein. And this perforator, which is about at the mid leg level, is known as Bassi perforator. So named perforators are Hunter's perforator, Boyd's perforator, Dodd and Cockett's perforator. See, these three are with the long saphenous system. Bassi's perforator is with short saphenous system. Now, this short saphenous system joins at the behind the knee joint to join the popliteal vein. There is a valve here also. So if the short saphenous system is distended, you must occlude at the joint level where it joins the popliteal vein, and then same procedure is done. Empty the vein when the patient is lying down, occlude the pressure there, then make the patient stand again and look whether the veins become prominent. If it's slowly, gradually filling, that means it is the perforator incompetence. If it's not filling, that is perforator is fine, then release the pressure over here. Immediately it fills, indicating that saphenopopliteal valve is incompetent. Oh, I hope you remember this venous perforator, short saphenous system, long saphenous system, and how to utilize this. When the saphenofemoral junction is competent, the veins become prominent slowly, and that is due to perforator incompetence. Now, the multiple tourniquet test is nothing but occluding the saphenofemoral junction, one at the mid-thigh and one below the knee joint about 10 centimeters. So you are dividing the leg into one compartment, two compartment, and third. Now when it empty the vein and tie the tourniquet, at that time make the patient stand. Then look at which portion of the veins are distending. If this much portion only is distending, that is due to the perforators in the leg, which is incompetent. If this segment of the vein is becoming distended, that means it is due to the Boyd's perforator incompetence. Now, if this becomes prominent only, then you know it is saphenofemoral incompetent. But if the mid-thigh level, it is the Hunter's perforator incompetent. And that is the use of multiple tourniquet test. There is nothing like the number of tourniquets are limited to 3, but it is the intelligent use of multiple tourniquet tests to locate the perforator. Now, short saphenous system, you ligate above the leg, knee joint, and then below the knee joint, and one. Now you look at the thing, saphenopopliteal junction. If this segment fills up, it is due to saphenopopliteal, and if this segment does not fill, and then if this veins fills up, it is due to the basi perforator. So that is the use of multiple tourniquet tests. All these tests are done making the veins empty in the lying down position and then tying the tourniquet to locate the site of incompetence. Now, clinical examination of varicose vein. This is very important. You must know. One important thing you must remember, you must examine these patients both standing and lying down. Standing because the pressure will increase and becomes obvious. Lying down, the venous pressure reduces, so it may disappear. So first thing, like all examination, infection, palpation. Now inspection, you look at both standing, lying down. Expose the patient from the groin to the lower foot, lower leg. Now foot also should be seen. Now look at the obvious limb for which system which is involved. Is it the short saphenous system or which is the long saphenous system? So you make out how the veins are distended both in standing as well as lying down, and to see if there are any skin changes or not, which system is involved. Now look for signs of thrombophlebitis. That means it is tender, erythematous, redness is there. Then venous changes. Now look for pigmentation on the medial area, which I told you, it is known as gaiter area. Now edema is there compared to the contralateral. Always compare the contralateral side if it is normal. God has given us two things everywhere. That is only to compare and see. Always compare the contralateral side and see whether there is any discrepancy between the two sides. Same thing, any examination, always look at the other limb. And even if you look at the thyroid, look at the left side and the right side. So always gives you a comparison and make use of that. Now there is the edema. Like I said, lipodermatosclerosis, whether changes are there, which is known as atrophy blanche. Now, then when there is distension of the calf muscles, which is become big with a narrow constriction at the ankle, that is known as inverted champagne bottle appearance. Now, obviously look for any ulceration. Usually ulcers are seen in the medial aspect of the leg, which is known as gaiter area. Then atrophy blanche. This is because of the constriction and the veins are drained out. The skin becomes pale over the healed ulcers. Then there is loss of skin appendages like hair follicles and all, which will give rise to appearance typical, which is known as atrophy blanche. Then look for varicose veins. On the medial aspect, you see which veins are distended, are they compressible or not, are they thrombosed or not, and any defect in the deep fascia. The perforators go from superficial to deep, and this defect in the deep fascia, because the perforator incompetent, is known as Fegan sign, Fegan. I'll be mentioning that. Then if there is localized swelling at the saphenofemoral junction, which is compressible, that is known as sapina varix. Then always palpate the pedal pulses, dorsalis pedis, posterior tibial, popliteal, and femoral artery. Always palpate. And then palpate the abdomen for obvious cause of any mass abdomen which is pressing over the venous vena cava or the iliac veins, which can give rise to dilated system. So look for the pedal arterial pulses. Always palpate the abdomen for any obvious presence of any mass. Now, special tests which can be done to make out which is. Now, this is to look at the valvular insufficiency along the course of the thing. This is known as tapping test or Schwartz test. Now, palpate over the saphenofemoral junction, which I mentioned is 2.5 centimeter lateral and below the pubic tubercle, and tap distally in the leg. If you feel a thrill, that is due to the valvular incompetence. Now, Trendelenburg, I mentioned, this is to make out the saphenofemoral valvular incompetence. Now, this patient test is done. Make the patient lie down and then empty the vein. Leg is raised to empty the vein. Saphenofemoral junction, you put your thumb across and compress it. Now, once you do this, make the patient stand. Along with the compression continued. The vein, your finger should not be removed, then ask the patient to stand. Now, if the veins do not fill immediately, that means it is due to the saphenofemoral junction incompetence. Now, release the thumb pressure, and then you will find that the veins are becoming prominent from above downwards. This is classical Trendelenburg, and Trendelenburg test is done to look at the saphenofemoral valvular incompetence. Now, multiple tourniquet test, which I said, ligate at the fixed site so that you will make out which is the perforator incompetent or which is the vein which is incompetent. And this is not 3 tourniquet previously just to mention, but it is the intelligent use of multiple tourniquet to locate the site of perforator incompetence. And this test is also known as Ochsner-Mahoney test. Now, this is the multiple tourniquet. See, one at the saphenofemoral junction, you either pressure or tie a tourniquet. After making patient lying down, empty the vein, then tie a tourniquet, make him stand. Look at whether the veins are becoming prominent or not. If they are not prominent, that means it is due to saphenofemoral valvular incompetence. Release the tourniquet, immediately you can see the veins filling from above downwards. Classical description of saphenofemoral valvular incompetence. In multiple tourniquet test, one is at the saphenofemoral junction, one above the knee joint, one below, one hand breadth above the knee, one hand breadth below. Now this will isolate saphenofemoral level, mid-thigh Hunter's perforator, this is the Boyd's perforator, and then this will be Dodd and Cockett's perforator. Now if the veins, make the patient always lie down, empty the veins, elevate the limb, empty the vein, then tie a tourniquet at these levels. Then ask the patient to stand. Now, if the veins become prominent here, that means it is saphenofemoral. And if this is tied and it's not visible, release this tourniquet and see. If this is empty or this vein is this valve is incompetent, then you start releasing from below upwards. So always release the lower tourniquet. If this fills up, that means it is the Cockett's Dodd and Cockett's perforator incompetent. If this segment is filled, that is due to the Boyd's perforator. If this segment is filled when standing, it is due to this Cockett and Dodd's perforator. If it is due to this, it is Hunter's perforator. If this segment is filled, it is due to the saphenofemoral junction anomaly. So this is how you are going to make out by multiple tourniquet test. Now this I have explained to you about the how to tie, and always make the patient lie down, elevate the limb to empty, then ligate the tourniquet, then gradually release from below upwards. Now, one important thing nowadays is the use of handheld Doppler or venous Doppler study. This is important to make out whether there is saphenofemoral valvular incompetent, and more if you look at the thing, it is due to to make out whether the deep venous system is patent or not. If the deep veins are thrombosed and the veins are secondary, then you have no choice other than conservatively managing these patients. If the deep system is patent, then you can treat this superficial system. Now, the probe is placed over the saphenofemoral junction. Then squeeze the calf muscles. When there is increased flow towards, you will hear a noise like that. And that is the description of. And at the level of perforators, you can keep the probe and see if there is any increase in the flow or the noise, which will indicate incompetence. So this is the handheld venous Doppler study. So Doppler examination is an important thing, and main thing is to locate the patency of the deep venous system. Now other tests, Perthes test used to be mentioned, that is to look at the deep venous thrombosis. But nowadays nobody does. Doppler is the ultimate study to make out the deep venous system. Fegan's test I mentioned, when the patient is standing like this along the medial side of the tibia, you just make out those openings or the veins which are prominent, mark them. Then make the patient lie down, empty the vein, then palpate along the medial side of the shin. And then if you find defects in the deep fascia where you had marked earlier, and that is the Fegan's test. I mentioned already the multiple tourniquet is also known as Ochsner-Mahorner test or intelligent use of multiple tourniquet. Now coming to the management of varicose veins, usually it's start with conservative treatment if patient is less symptomatic. So ask them to keep their legs elevated when they are sitting, and when they are try to walk on the toe, tip toe, so that calf muscle starts functioning. So all these are all conservative. And then you can even advise this patient to wear compression stockings, which helps to prevent deep venous thrombosis. One precaution you must always is to measure the ankle brachial pressure index. If there is reduction in the ABPI, that is ankle brachial pressure index, then this pressure can make claudication pain. So always measure ankle brachial pressure index before you advise the patient to wear compression stockings. Now, if the pressure is low, you can use low compression stockings. Pressure is normal, you can go for higher to compress the veins. Now, sir, other therapy is sclerotherapy. If it is localized varicose veins, then you can inject sodium tetradecyl sulfate into the veins. This will cause reaction of the endothelium and then fibrosis. So this will prevent recanalization of the vein. So sclerotherapy has been used, and the drug sodium tetradecyl sulfate. Now, previously, they always used to say if the saphenofemoral junction is abnormal, you can straight away say what is known as flush ligation of saphenofemoral junction, ligating all the tributaries which I mentioned: superficial external pudendal, superficial epigastric, superficial circumflex iliac. After that, flush ligation and then stripping from below upwards. But nowadays they are doing localized excision or avulsion of the veins if it is due to deep perforator import. And currently what is known as luminal or endoluminal ablation using laser. So this segment, the venotomy is done, the laser fiber is introduced at the site of the focal, and you ablate the vein. That will destroy the vein so that there won't be recanalization of the vein. So Trendelenburg's ligation and stripping used to be the surgery, but nowadays the saphenous veins are used for many bypass surgeries. Coronary artery bypass surgery, where the veins are required. When there is block, the saphenous vein is used to bypass the coronary artery obstruction by reversing the vein. Reversed vein graft means the flow is from below upward. So you make the vein upside down. That is the reverse vein graft, which helps the flow in the along the valves. So this is the basis of management, and the management has to be catered according to the patient and their job, from conservative to surgical therapy. Now, like I mentioned, this Trendelenburg surgery is flush ligation of the saphenofemoral junction with ligation of tributaries: external pudendal, superficial epigastric, superficial circumflex iliac, anterolateral vein, which can be there, and then remove this whole system. So this is the Trendelenburg's surgery. You must remember these branches, because if they leave the branch, they can become bigger and give symptoms again. So this is the basis of Trendelenburg's ligation and stripping. So I hope you know the etiology of varicose veins, what complications it can cause, how to examine and evaluate the patient, stage the disease according to CEAP classification, and advise the management, cater to the patient, and the decision should be taken together with the patient, telling them about the advantages.
So can you please unmute yourself, sir? Sir, you're not audible.
Yeah. Now?
Okay. Yeah, sir, you're audible.
Yeah. Okay, students, I hope it is clear, the varicose veins. This is an important thing both for practical as well as theory examination. I hope you get the concepts clear so that this will help you in the long run. So you have learned. Happy learning. Thank you for your patient hearing.